would like to welcome everybody to today's webinar. This is Scott Mash with CliniSync. And the title of today's webinar is Protecting Yourself Against a Charge of Information Blocking, Interoperability in the HIE. All attendees are muted automatically and will remain muted throughout the webinar. There will be a question and answer session at the end of the webinar, and questions can be submitted at any time using the questions feature of GoToWebinar. We would like to thank today's presenters, which are Dan Paoletti, the CEO of CliniSync, Joe Jones, the in-house counsel here at CliniSync, Alan Killworth, who is a partner and a healthcare attorney at Bricker & Eckler, Terri Keeling, the Vice President of Information Technology for Univesity Hospitals, and Fred Gutwirth, the IT Director of Clinical Applications at Univesity Hospital. With that, I'm going to turn it over to Mr. Dan Paoletti.
Good afternoon, everybody, and thank you for taking some time this afternoon to cover the new information blocking rules. Again, this is an output of the 21st Century Cures Act. The information blocking rule was expected to go into effect starting November 2nd. There is some information that has come out that they may postpone that again. Nothing has been finalized yet, but we do expect that may get pushed back a little bit, and we'll communicate as soon as we know anything more. But having said that, let's go ahead and get started. Go ahead, Scott, next slide. Again, just for those of you that may not be overly familiar with us, the Ohio Health Information Partnership, which operates CliniSync Health Information Exchange, we're a nonprofit 501c3 founded by the different associations in the state and the Department of Insurance. We're run by an independent board of directors that represent care across the continuum, and an advisory council, which is really also a governing board, which helps us make sure the bus is going in the direction that the stakeholders want it to go. Next slide, Scott. As far as participation across the state, again, we have the bulk of the residents of Ohio in our master patient index, as well as many outside of Ohio. We have 155, soon to be 156 hospitals in Ohio, and a couple in Kentucky and West Virginia, as well as a multitude of entities, long-term care, home health, and other entities across the continuum. We also now are working with 12 health plans to create that bidirectional flow between providers and health plans. Next slide, Scott. What we want to do is kind of dive into the actual rules themselves. Again, I'll turn it over to the experts on that, and then we'll circle back on how, by working with CliniSync, that it can help protect you against a claim of information blocking. With that, I'd like to turn it over to Joe Jones, who is the CliniSync General Counsel and also Privacy Officer, and Alan Killworth with Bricker & Eckler, our law firm that we use for outside counsel, and does really just a tremendous amount of great work with so many of the healthcare providers across the state. With that, Joe, I'll turn it over to you.
Thanks, Dan. Scott, you can go ahead and go to the next slide. So interoperability is defined in statute, and it means it's such health information technology that enables the secure exchange of electronic health information with or the use of electronic health information from other health information technology without special effort on part of the user. Essentially what that is basically machine-to-machine talking, where the users don't have to do too much in there. It also allows for the complete access, exchange, and use of all electronically accessible health information for authorized use under the applicable state and federal laws. So, you know, for TPO, treatment, payment, or healthcare operations, any kind of health information technology that will allow you to access, use, or exchange it. And it does not constitute a information blocking as defined in section 3022A of the statute. If you go to the next slide, Scott. So now on to information blocking. And information blocking is defined as a practice that, except as required by law or specified in the rules, is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic information. So basically, that's any act that an actor might do that would interfere with anybody's ability to access, use, or exchange information. And access, use, and exchange information is a combination of bidirectionality in the flow of the information, using it, ingesting it, able to actually do something with the data. And for providers, for healthcare providers, they are defined as an actor under the information blocking rule. The provider, there's an intent here that the provider must know that the practice is unreasonable and likely to interfere with data exchange. So if a provider is, CMS is calling you, saying you're information blocking, part of that is it's a case-by-case analysis, and they will have to show that the provider knew whatever practice actor they were engaging in was likely to interfere and unreasonable interference with the data exchange. So there are some new rules that are designed. These are new rules designed to prevent information blocking in the following cases, and it's by vendors with their clients, providers with other providers outside their health system, and by providers with patients. And I guess we can clarify here too that in the context of information blocking, we are talking more with provider to provider exchange here in the context of this webinar. Information blocking currently, it does not apply to payers unless the payer is covered under the definition of a healthcare provider. So kind of like a home healthcare plan or something like that. Scott, if you go to the next slide. So the scope of the information covered is this applies to electronic health information defined as EPHI, as defined by HIPAA, to the extent would be included in a designated record set. So with that, there is a caveat that until May of 2022, the data that's required to be exchanged is limited to the United States Core Data for Interoperability, or USCDI. After May 2nd, 2022, unless something is changed in the interim, all the information required to be exchanged will be, I believe, all the electronic health information that you have. And the USCDI is similar to former core clinical data sets with new additions of provenance data, 8 types of clinical notes, additional demographic data, and pediatric vital signs. And again, the information blocking rule is an act or practice unless it's required by law. So if there's some law that prohibits you from exchanging the data without either A, first obtaining consent or something like that, or if you can fit into one of the exceptions, you have to provide the information, or you may get a potential claim for information blocking. Scott, next slide. And speaking of those exceptions, these are the 8 exceptions under the rule, and I'll go ahead and let Alan Killworth dive into those a little bit deeper.
Yeah, hey, this is Alan Killworth. Hopefully everyone can hear me. I'm going to take over for this piece of the presentation and talk a little bit about one exception in particular where the use of CliniSync as a health information exchange would fit, we believe, in assisting with meeting that exception. As you see on these on this particular slide, 5 out of 8, most of the exceptions actually apply when you're denying the request, when you're not providing the information. And so, we're not going to go through those here. Those really are not what we're talking about. We're talking about facilitating exchange of information through CliniSync. And so we're going to focus mostly on the content and manner exception, which is one of the 3 in this second group of exceptions that apply when you are fulfilling the request, but there may be there are some limitations to what you're providing or in how you're providing it. And if you can fit into one of those exceptions, then you are assured that you're not going to be information blocking. Keeping in mind that you don't have to meet an exception to avoid information blocking. It's sort of like a safe harbor. If you meet an exception, you are assured that you're not going to face a claim or a charge of information blocking. If you don't meet one of those exceptions, you still might not. They would still have to. There would still have to be a showing that you did did satisfy the requirements for information blocking. Joe went over those earlier. As he mentioned, there's a knowledge-based and a reasonableness-based element to it that would also potentially work to defend or to demonstrate that you are not engaged in information blocking. But for now, let's talk about one of the exceptions that may apply in particular. And again, this is when we are fulfilling the request from a provider-to-provider exchange. Go ahead and go to the next slide, Scott. As Joe as we're transitioning slides, as Joe mentioned, what we're really talking about with CliniSync is a provider-to-provider exchange of information. Information blocking would apply in other contexts, as Joe has already mentioned. So a patient or access request, or even a payer's request, or some third party's request for information. You might have information blocking issues as well. We're going to focus primarily on provider to provider, as that's the area where CliniSync facilitates that type of exchange and that type of interoperability. So how does CliniSync fit into the information blocking puzzle here? Really in two ways, we think. One is within the general application of the definition of information blocking, which Joe has already covered, and we've referenced a few times about this reasonableness standard, this knowledge standard. There's a potential defense that would be supported by a demonstration that the provider engages in interoperability, that they don't information block. And it's sort of a basic fundamental concept. If you are making that information available through CliniSync or through an HIE, then it seems unreasonable to suggest that the information was somehow withheld and therefore constitutes information blocking. So this is kind of sort of a really basic concept, of course. CliniSync has been facilitating health information exchange for quite some time, and that's what they do. It's the opposite of information blocking. They really are facilitating the exchange of information. And so if you are a provider who makes that information available through CliniSync, it's not an automatic exception like there are under some of those identified exceptions. But we do think it goes to the point of this reasonableness concept and this knowledge concept. So let me give you a quick example. If a provider A asks provider B for certain patients' information, and for some reason it was either unavailable, or there was some trouble getting it, or wasn't made available in the way that they wanted it, it was alleged or suggested that there was information blocking. If provider B could show that same information that was requested was available through CliniSync, it would be, we think, certainly a factor in the determination as to whether or not that there was an information blocking, because it was clearly not the intent of that provider B to deny the information or to make it unavailable or to interfere with access. The access was provided and was certainly available through CliniSync. So just on a very broad and general basis, it certainly, we think, goes to the point of interoperability being facilitated and participated in by providers when they're using CliniSync. The second way that CliniSync may impact any type of information blocking claim specifically is with respect to that content and manner exception, which I mentioned on the last slide. This is one of the exceptions that applies when you are actually fulfilling a request, when a provider is fulfilling a request. If you fulfill the request consistent with the content and manner exception, you will be assured that there's no information blocking. You'll meet that exception. The content and manner exception has two parts: the content standard and the manner standard. The content standard is very simple and simply says that you must provide the information requested that is limited to either EHI after May 2nd, 2022, or until May 2nd, 2022, USCDI. So, meaning there could be no information blocking if someone's requesting information outside of USCDI, or if you were not providing that information. You still may have other, may still have to provide that under other rules, for example, the HIPAA access rule for patient access. But for information blocking, they're only looking at USCDI until May 2022. So if the information provided is USCDI, you're going to meet the content standard. Pretty simple. The manner is a little bit trickier, a little more complicated, but I shouldn't say tricky, fairly straightforward, even though there's a few more steps involved. Under the manner standard, the provider will meet the exception if they fulfill the request that was in the manner that was asked. So if someone asks for this information in a certain way and manner, and you comply with that, you've met the content and manner exception, and there can be no information blocking. So that makes all the sense in the world, right? Someone asks for the information, you give it to them as they've asked for it, you're going to meet the exception for content and manner. If the if the request if the provider is unable to fulfill the request from a technical standpoint in the manner requested, then the provider still meets the exception if they fulfill the request in an alternative manner using a prioritized list. And the very first stop on that prioritized list is the use of certified technology specified by the requester. So again, here's where we think CliniSync comes into play. CliniSync facilitates the exchange of information through certified technology. So if you get to this point where a request is made, the manner that's requested, you're not able to fulfill it, but you are able to fulfill it through the use of certified technology, through an exchange, through a health information exchange like CliniSync, you should be able to hopefully fall into that content and manner exception under the first alternative manner, and therefore be able to say the information was provided and was provided, through an alternative manner, and therefore we meet the content and manner exception. So that really would be a helpful aspect of the use of certified technology to fulfill a request through CliniSync, through an HIE, and therefore having that ability to say we can satisfy the content and manner exception. All right, next slide, please. So let me talk a little bit about a few more sort of broad strokes issues with respect to the interoperability push and concept and some of the other rules. CMS and ONC issue as was referenced, twin rules on May 1st, the CMS final rule and the ONC final rule work hand in hand. The CMS rule really does go to patient access. It's really, it's this push for moving everyone towards interoperability and towards making sure that when health information is requested, it's made available, it's made accessible, and so the access piece of this goes hand in hand. And again, that a lot of the access piece of it is with a patient request, a direct access by a patient, and so that's beyond the scope of this webinar. But it really is a similar concept and goes hand in hand with what we're talking about, which is making the information available across networks for all providers to have access to it. And the push for interoperability is really this push towards that concept. Okay, go next slide, please. As that next slide turns, I'll mention that we did a prior webinar, CliniSync did a prior webinar specifically on the patient access issue and some additional aspects of that CMS final rule. And hopefully you were able to listen to that seminar as well, provide a little bit more detail. This patient access right is a balance of privacy with the need to coordinate care, and this is a rule, and the information blocking rules here as applied to patient access requests. Well, it is going to require hospitals and other actors, other healthcare providers, to make data accessible via portals and apps, through a lot of different ways, and that might currently not be provided. We've been moving towards that, certainly moving towards that world, and we are continuing to move towards that world. And this information blocking rule and the applicability to the patient access rule will really increase it. Patient access rule has been around, of course, since HIPAA, and we've had patient access issues for a long time. These information blocking rules will work hand in hand with that, and will push that concept, because it will penalize the denial of access, essentially, for not complying with patient access. We note here at the bottom, CliniSync doesn't give direct patient access. That's something that's going to be one-to-one with providers to patients. And I want to note that the information blocking rules recognize that CliniSync, as a business associate, has the ability to exchange information between providers, between covered entities, because that's the way that, as a HIPAA business associate, CliniSync has been set up by the folks who contribute data. So there's no provision in those documents for direct patient access. And so CliniSync doesn't really have a role in the direct patient access piece of this. Okay, next slide, please. This slide mentions the development of an interoperability network, which is still in the works. We're still sort of in the early stages of this. But the structural framework for a national network for data exchange, known as TEFCA, is certainly moving forward. All of these rules will assist with that project and will make a national network for interoperability of data information certainly more functional and more functional on a more rapid basis. The new standards, the US CDI standards that Joe mentioned, are designed to increase the usability of this data with an emphasis on patient identification. And again, once we get to this a national exchange, a national network, we really will have, we'll hopefully have achieved this goal of interoperability where this information will be available across networks on a nationwide basis. I'd like to note also that in the information blocking rules, the ONC mentions TEFCA and says, in the commentary, noted that some folks had requested that an exception be specifically identified, that if you participated in TEFCA, that would be an exception to information blocking. They didn't approve that, and that's really sort of similar to what we mentioned on the prior slide about use of CliniSync. As working towards an exception or that content and manner exception. They declined to build that into the rules, in part because TEFCA is voluntary, it's very much in the embryonic stages, and it's not fully operational yet. The ONC did say that they would revisit that, however, in later rulemaking. So it's a possibility that we will get there at some point. I'd like to note also that ONC, in that commentary about TEFCA, actually mentioned themselves in that rule. They said, if you are using a network like TEFCA, and to our point, like CliniSync, as you mentioned a few slides ago, ONC said you might qualify for other exceptions, including the content and manner exception, if what they call the one-off interface was infeasible, or you were technically unable to meet that interface. You might be able to qualify for one of the exceptions if you did participate in the TEFCA network. It was a very similar analysis to what we were just talking about with respect to the content and manner exception potentially being applicable when the information is available on the health information CliniSync network. Okay, next slide. All right, I'm going to turn it back over to Dan to talk about the national framework and some additional information in that area.
Thank you, Alan. Thank you, Joe. Next slide, Scott. So as Alan mentioned, to make information available, you have to be part of a national network. In Ohio, CliniSync is a robust network, but we also have to connect to these national efforts. TEFCA was, out of the Cures Act, as Alan talked about, was kind of the concept. It's still not quite there yet. So let's talk about what is available. And really, there are 4 national networks, and I'm going to exclude EHR within EHR networks because, again, they don't really define those as it's interoperability from different EHR systems. So there are really 4: eHealth Exchange, Care Quality, Direct Trust, and Commonwealth. We'll dive into each of those a little bit. Next slide, Scott. The work through CliniSync is, again, we will connect you to all 4 of those national networks. We're going to focus on eHealth to start here. Information from the eHealth Exchange is available in multiple different ways, either through a direct EHR connection, through IHE-based queries, query and retrieve, through single sign-on through CliniSync, or through the web portal community health record access if a provider doesn't have the integration. That information comes through as a continuity of care document And again, currently, providers have access to the VA and the DoD records if they so choose. We are working through the end of this year, most likely before the end of this year, we will be also part of the eHealth Exchange Hub. We are actually technically already, but the eHealth Exchange Hub will send a distributed query to anybody on the eHealth for a patient search and bring that back through us and then make it available to you. That should hopefully be live soon. We're waiting for eHealth to help us finalize that. Next slide, Scott. The information from those that work with us, though, so those that are contributing information through CliniSync to really promote this national interoperability, again, through the EHX Hub, as I mentioned, we'll make that information available to anybody that's part of that national effort. CliniSync is already a responder on the EHX Hub, so for those providers that are contributing and participating with CliniSync, information is being made available if they're treating that patient outside of Ohio and they are part of the EHX Hub. And again, in progress, as I mentioned, that information will also be flowing back to anybody who's connected to us from any of the EHX Hub participants here by the end of the year. Next slide, Scott. The other national effort, care quality, we are going to use our connection to eHealth Exchange Hub to also connect to any of the care quality network. They will be a bridge for us, and again, that will probably be a first quarter 21 effort. So anybody that is part of the care quality network will also be able to query information from CliniSync. And again, any of those participants who aren't a direct care quality endpoint can also query care quality through the CliniSync connection. Next slide, Scott. Direct trust is also another national standard. We've been talking about query, but this is a push. We are the certified HIS for a big chunk of the state, but again, there are multiple different health information service providers where that CCD, USCDI compliant data format can be made available through a push of information. We can also, if you get requests from providers to receive that push of information and they don't have direct messaging capabilities, we can also set up a no-cost ability, a web direct address for them so you can push information to them, which was very similar to the meaningful use standards. We're kind of going back to that whole transition of care and meaningful use standards. So again, this is another way to be compliant with making sure that requests are met. Next slide, Scott. Again, we will be connecting through the Health Hub, which will get us connected to Care Quality, and then also Commonwealth, which is a Care Quality implementer. So as we finish up all those connections, again, you will be able to say to any provider that requests information that the information is available through any of the national networks or through direct trust or through a direct connection with CliniSync. And again, all of that kind of goes into what Al was saying. These are the national standards, the national exchange efforts, the way that information is going to be made available. Next slide. So it's great to talk about how it is going to be done. We need to talk about a little bit of documentation that'll be available for you, again, in case you are ever, someone claims that you're information blocking. So we're going to kind of dive through that a little bit. Next slide, Scott. Again, from a service perspective, there is multiple ways where information is made available through CliniSync to providers that are caring for the patients. We've talked about a lot of those. There are some up here that we haven't. They're more direct connections, but again, there are multiple options for providers to receive information in a USCDI compliant and other HL7 compliant fashions. I'm going to turn it over to Joe to talk about some of the specifics around the documentation. Joe, you want to take it from here?
Sure. Thanks, Dan. Scott, can you go to the next slide, please? So documenting your interoperability and information sharing. So some of the documentation that we here at CliniSync have and that we provide to your providers are our CliniSync governance structures and the policies regarding the use of the data. We have on our website, we have a list of our connected vendors. We also list all the connected hospitals, all the contributing providers, and we also provide the return of investment reports for our hospitals. And a lot of what that information will include with how much information is being sent out over through the HIE. So you can actually see how many messages went out in a month, quarter, year, how many times your data was accessed, and I believe we might even actually be able to show you kind of the systems that actually access the hospital. Some of these things that the organizations may want to have documentation on would be their patient access policies. And again, as Alan mentioned earlier, the patient access policy, our BAA does not permit us to give it directly to the patient. So typically what we do is that if any patient comes to you, the provider, and asks for a copy of their record, all you have to do is contact us, and you can more than likely contact me in general, and we will make sure that we provide that information to you within 10 days per our business associate agreement. Any other organizational policies that you have related to privacy and security of the data, and also any policies specific to exceptions for release of data. So psychotherapy notes, if you have a Part 2 facility within your system, anything like that, those are some of the types of documentation that you may want to have. You can go to the next slide, Scott. And then also our CliniSync policy manual. So this is on our website as well. You can go access this and download it anytime you want. And in particular, as Dan mentioned with the national exchanges, we actually have in policy E that says part of our permitted data use is to connect to eHealth Exchange or any other national health information exchange so that the data could go anywhere, any other providers around the country. Next slide. And I will go ahead and throw this back to Dan to cover the interoperability ROI reports.
Yeah, so just an example, thanks Joe, of the kind of information. So here over the last year, you can see we've on your behalf, we've done tens of millions of transactions to allow the data to follow the patient. Ohio has become a true model of interoperability. We'll focus on that a little bit more, but interoperability is already happening. Information blocking, for the most part, is not. So Ohio is in a really good shape. And again, these will be customized for each individual facility that's contributing information, so you have that documentation. Next slide, Scott. In addition, we want to be able to provide a kind of a certificate of what we're thinking, just so you have additional information from us. So we're developing a certificate of interoperability for your documentation records as well, that you can have upon request. And we do that for some meaningful use requirements now. Next slide, Scott. And again, so the goal here is for anybody who is currently participating in publishing data through the CliniSync network. Again, we are working with a multitude of hospitals. Next slide, Scott. And again, a multiple of additional organizations now, ambulatory post-acute care facilities. Again, all these entities that are moving information through the network, that really speaks to this webinar and will help you stand up to any information blocking claim. Next slide, Scott. Again, we are integrated with most of the inpatient and ambulatory vendors. And next slide, Scott. You can go through the next two slides. Go to the next one as well. And again, so integration in most of this work is already being done on your behalf. I would like to, take a minute to introduce a couple of people who've just done a remarkable job when it comes to interoperability in the state. Northeast Ohio has worked collaboratively over the years to really become a model of true interoperability for the country. That effort was really led by the hospitals, University Hospitals, Cleveland Clinic, Metro, Bon Secours Mercy Health, St. Bees and the Sisters, Southwest, Fisher Titus, Lake Hospitals, and there's others. And University Hospitals has really been a true champion here. Again, it's my pleasure to introduce Terri and Fred, who are going to talk to you a little bit about what they're doing. And University Hospitals has worked so hard over the years to make sure that the data can follow the patient and is available to anybody treating that provider or that patient in the community, and really becoming that shining star of interoperability in the state. So it's my pleasure, again, to introduce Terri and Fred, and I'm going to turn it over to you guys, and I appreciate you taking some time to talk about what you're doing here.
Sure thing. So thank you, Dan, and thank you to you and your team for inviting universities to hospitals to share today. Those of us who work in healthcare share the common interest and the pursuit to provide our patients with the best care we can, and we all know that sharing information across our healthcare organizations is an important component of providing good healthcare. UH has been a believer in information exchange for a long time. As Dan said, we joined the CliniSync HIE, the Ohio Health Information Partnership, early in the journey in interoperability. We do value our relationship with the CliniSync HIE team. We consider the HIE as part of our organizational solution set. When we are faced with challenges, we often turn to this group to see if they are also working through the same challenges and if we can find a solution within the HIE. They recognize the importance of interoperability for the region and brought us all together as a group to tear down the walls of competition and to really be talking about the information and making sure that we are improving our information sets and adding quality. They also recognize the importance of the data view for our payers. And this is critically important to us at university hospitals. We have a large ACO, and so being able to have that relationship and partnership to try to meet some of those demands has been incredibly beneficial to university hospitals. And as we're pursuing challenges like this, like information blocking, it's great to have you all, the CliniSync HIE in our corner and helping us through these challenges. And with that, I will turn it over to Fred, who will share kind of our current state and what we look like today.
Thanks, Terri. Good afternoon, everyone. Next slide, please. So I want to start off here today kind of with an overview of how University Hospitals is currently sharing data with CliniSync and then with everyone in the community that belongs as part of this. So today you can see we are actively contributing a large amount of data. We've been contributing our office notes, both in the ambulatory and the hospital settings for quite some time. We're live now also with contributing our CCDAs to CliniSync. We just went live recently with our hospital CCDA, and we've been live quite some time on the ambulatory side. So again, sharing all that visit data, the vitals, the problems, the medications through the CCDA. And then of course, like I said, our office notes, the actual notes that the providers are documented in. We have a very big belief that we have an open note policy at UH. We share that with CliniSync. We share that with with our patients through our portal. Of course, there are those exceptions that some of the laws, safeguard against, and we have those, appropriately safeguarded in these processes. But again, continuing that spirit of sharing data. Traditionally, for a while, since the beginning, a large contributor of our results, so radiology results, lab results, and as well as some of our cardiology results are also being sent into CliniSync to be distributed. And then, of course, all this works based upon our ability to present demographic and visit and registration data. So, just kind of the whole gamut there of what and how UH is contributing to the HIE. And then, of course, through the different mechanisms and offerings that were highlighted previously. Everyone in the community can benefit from that data in your organizations. I also wanted to highlight on there, I believe Dan went through kind of a sample of the ROI scorecard. You can see that's the one that's part of one of our scorecards that are presented to us quarterly. I just took a little sample out there just to give you kind of a visual of, again, how we're contributing. So again, you can see there monthly, through the result delivery, we are sending a little over 43,000 transactions out, to the participating providers that want to subscribe to that. A big win for us, as you can see there, and we'll talk a little bit, is our ability to access the community health record. So tracking, monthly, we've got over 400,000 views. So our clinicians and providers accessing the CliniSync community health record to try and look up data on their patients that may have had service or care outside of UH. And then again, a large number of alerts being sent to the community on patient movements from UH. So next slide, please. So this slide represents how UH is really using the data from your organizations in our everyday treatment of our patients. So again, traditionally, we're working through our electronic medical record. One of our biggest wins, like I said, is we've got an integrated launch into the community health record. So from our EMR, and I'll show you kind of a slide later a little bit, our providers and clinicians are able to, through a single click in patient and user context, access the community health record. And like I said, you saw there in a month, there was over 400,000 points of access. So it took us a while to get the word out in our health system, but folks are really taking advantage of that and really like that functionality that, if their patient is traveling somewhere in Ohio and, happen to have to get care at a different hospital or for whatever reason, our providers are now able to see that information without having to leave the EMR on there. In addition to that great connection built into the community health record, we also have a query and response document retrieval. So another alternative, we have a solution that's kind of built in where we can go out and retrieve the documents and bring them for viewing into our EMR as well, as an alternative if there's just pieces of documentation that our providers are looking for. So again, all within the EMR without having to leave, they can get access to information from CliniSync. The other item we have integrated into our EMRs, which is in pilot currently, is having result delivery directly into the EMR. So again, if a patient has to leave the system for a lab test or some other testing, and that test happens to be sent to CliniSync, and it's associated with a patient and a provider and our organization, we can get or was ordered by that provider, we can get the the result delivered directly into the EMR, which allows us to be able to task and notify our providers that the result's there instead of them having to just go out and look randomly. They can get notification. This really cuts down on the the need to fax and mail and things like that from outside labs. So again, we're in pilot with that. It's been going really well, but our hope is to increase the number of organizations we receive those results deliveries for directly into our ambulatory EMR side. And then again, we've been using Notify for quite some time. We are really looking to be able to integrate those notifications of when patients are, seen outside of UH again, and alert mainly our primary care providers that their patients that they care for may have been seen in the ED down in Columbus or down in Cincinnati or some other area. So we are working right now in development to switch over from Notify, where our practices have been kind of going to the more portal Notify view, and actually use the Dispatcher product, where we can actually send those transactions real time into our EMR, and again, task and alert our providers so that they can follow up appropriately if the patient has been seen outside of the UH walls. And then again, our accountable care organization, we have a large ACO, over 500,000 attributed lives. We have also started or have live that similar integration from Dispatcher into our clinical coordination platform that ACO uses. So our ACO nurse navigators and care managers, again, can get alerts on patients that are attributed to UH ACO, and know, if they've been discharged from an ED or if they've been seen as an inpatient in another hospital outside of UH. So again, they can, if they're actively following those patients, can follow up and provide the necessary next steps with them. And then lastly, something that's still in progress, but again, going very well, is we are integrating into our enterprise data warehouse information from the CliniSync Data Mart. And so again, this is centered around our ACO and the attributed patients to the ACO. So we provide CliniSync with our ACO panel, and in turn, they will be sending that information back to us to include in our data warehouse, so that we have the additional information that may reside on patients from their care outside of UH to include in any of our reporting or any of our quality reporting or any other metrics that we may be doing. So really, again, as Terri said, whenever we have the opportunity, we've been getting a lot of requests lately for payers to provide information to them on different results and metrics, and we're encouraging them, instead of trying to build off one-off interfaces to every single payer, and to really work with the HIE to get the appropriate contracts and things in place, so they can just pull the information we're already sending from there. So again, working with our partners at CliniSync to try and really leverage the data that we're already contributing in other ways. So next, in the next slide. And then this is just an example that I talked about. So it's something that we've had live for a while now. You can see there is, I've circled in red is a button in our EMR. We just call it HIE to keep it short and simple and not take up too much real estate on our desktop. But basically, the providers on the patients in the EMR, and if they want to go out and see if there's information, patient notifies them that they were at XYZ hospital, 2 weeks ago in the emergency room. Our provider can now go out, click on that button, and launch the community health record and look for that information, again, without having to leave the EMR. So lots of cool stuff that we've got going on, and it's been very well received as we move forward. Also did want to kind of, mention that our colleagues at the Cleveland Clinic have approached us, and we've been working on HIM initiative to try to go more paperless. And so really, looking and analyzing our request for release of information between the two organizations. The Cleveland Clinic's done a lot of analysis on what the UH requests that were coming in, and we've started the same work. And so looking how we can really leverage the CliniSync and the technologies and the offerings to handle those requests versus having to print and fax and scan paper between the two organizations. And we've got all these tools in place, but we still get the occasional or request for information outside of these tools. So trying to address that and find solutions there. So I guess that's where we're at currently. And I guess next slide.
Fred, I can take it over from here if you want.
Yeah, absolutely. Thank you.
Yeah, I just want to thank Fred and Terri. Just really amazing work. And one of the things I thought of is while they were talking, interoperability is a buzzword that's been around for years. The Cures Act, the goal of this was to make the data usable, because interoperability is only as effective as you can fit it into people's workflow. And I think everything that Fred and Terri just covered is, an effort to making sure it does fit in the workflow and the data is actually actionable and can be used. So, ultimately that's the goal, and just really great work. So thank you. The rest of the slides are just appendix, additional information for you. We won't go over this, but again, we wanted to provide as much information as we could. With that, Scott, I'll turn it back over to you to finish up.
All right, and we will now start our question and answer session. If you do have a question, enter it into the question feature or into the chat box, and we'll make sure we ask every single question. First question, are employers expected to provide a direct address for locum tenens providers? I would say from Kathy sitting here with me in the room, and we're shaking our heads no on this one, that locum tenens would not be required to have a direct address because they are working in place of the provider for which they're covering. So the provider for which they're covering, of course, would need to have a direct address. So next question, is there an advantage to being connected to more than one HIE or exchange partner?
So this is Dan. I'll start with that one. I think the answer to that is maybe. Our goal is, from the CliniSync perspective, is how do we bring additional benefit to our stakeholders so you don't have to connect to multiple different HIEs. And again, the goal here is to make the information more usable, be connected to all those different networks, and give you one access point. But there may be instances where you need additional connections, like to the Social Security Administration through the eHealth Exchange or something like that. So what we want to do is work with each of our stakeholders to make sure we're not duplicating data. So if you are connected to another network, we want to exclude that information so you're not getting duplicate information from us. But in some cases, there may be a need, but we hope to minimize that need.
Okay, next question is, will the source or history of information be required, or will information such as notes be required from the time it goes live forward? So I think this question is more about prevalence of data.
Yeah. So this is Alan. I can try to answer that. Kathy and Scott, jump in if you want to. But I think the question is, since US CDI includes notes, clinical notes as one of the elements or one of the categories of US CDI, and then also providence data, which is sort of authorship, that metadata, do you have to include it? How far back you have to include it? I think it's the question. There's nothing in the information blocking rules that cuts it off or that says it only applies going forward. So if you have it, if it exists, then I think it needs to be disclosed or made available to be consistent with the information blocking rules. You could come up with maybe able to fit into an exception such as infeasibility if you have to go back and create that data, for example. But if you have it, for example, notes, there was nothing that says in the information blocking rule that a note created or a note that exists on today, on October 15th, doesn't have to be provided and only has to be provided on November 2nd when the rule kicks in. I think just like medical records that existed last year, or the diagnosis information, the parts of the medical records that are USCDI, those are all expected to be available on November 2nd. So would notes. Meaning, just in summary, I don't believe it's safe to say that all notes prior to November 2nd are somehow excluded.
Awesome, thank you, Alan. And the next question is for the UH team. Have you been able to train your staff on how to import information and do the reconciliations from the outside data?
So this is Fred. So today, through the processes we have, we're not importing the data directly. It's all viewing of data only. The only exception to that, again, would be the results delivery that we're working on. Those results are automatically filing discreetly through our interfaces, but everything we have today coming in from CliniSync is kind of a view into the data only.
We got two more questions. I think we have just enough time. These will be really quick ones. Dan, I think this one's for you. Is CliniSync planning to participate in TEFCA when it becomes active?
Yeah, great question. So two quick pieces on that. One, there will be a data governance issue. TEFCA right now is still considering bulk query capabilities for non-clinical use to other entities. So we have to kind of wait to see what the final rules do. We do plan on being part of it if we can, most likely through the eHealth exchange. We've been keeping in coordination with them. I do believe they will probably go down this route. But again, part of it is depend on the actual secondary uses or the use of the data. We just have to wait to see what comes out with the final version.
Okay. We did have just another question come in. It says for the MIPS program in 2021 is proposing to give us 40 points for the two HIE measures for being fully interoperable. It sounds like your certificate of interoperability would allow us to make this claim. Do you agree? What about being interoperable for providers who still don't use an EHR, for instance, some psychiatrists?
First of all, we're going to be doing a webinar that is MIPS facing as soon as that rule becomes final. But it is our belief in the language of that rule that our role as the HIE would, and your connection to it in a bidirectional manner, would fulfill that requirement. But we will be doing a specific webinar on this issue and on meeting interoperability by ambulatory and community providers.
Okay, we're going to make this next question our last one, and I believe this one will go out to Joe and Alan. Is participating with an HIE enough to avoid a charge of information blocking?
Alan, I'll go ahead and make a quick statement on that, and then you can jump in. Participating in an HIE will not itself alone prevent you from getting a claim of information blocking. It can help in a defense of information blocking, and especially from a provider-provider sense, but there are going to be other instances, like for instance, some of the exceptions, the privacy exception or the harm exception. If that's coming from a patient or another provider and you withhold that information, you're going to have to make that determination on your own, but it will help greatly, I believe, in a defense or especially since all these are going to be viewed on a case-by-case analysis. And Alan, I'll go ahead and let you fill in where I.
Yeah, no, that's great. That I would agree with what Joe just said. Information blocking is a much bigger concept than just HIE types of exchanges. So information blocking applies, as you mentioned, to patient requests or third-party apps and other types of requests that really aren't provider to provider through an exchange. So participating in a health information exchange would not be some umbrella type of immunity to all information blocking. But as Joe mentioned, we do think it can assist in demonstrating that you comply with interoperability and are not engaged in information blocking generally, and then potentially under the specific content and manner exception, and if, as mentioned back on slide 11 during this presentation.
Well, that is the last of our questions. I would like to thank all of our presenters and all of those behind the scenes here at CliniSync that helped to make today's webinar a great success. We did record the webinar. I will be posting that to the CliniSync YouTube channel within the next day or two, and we will also be sending out a copy of today's slides. So we'd like to thank you all very much for attending.